Thanks, Gary. Morning. So this is the clicker. Okay. Our approach to this really is to look at opioid use and abuse as well as chronic pain in the bucket of chronic disease, like we would diabetes and other conditions of chronic disease. In that bucket are these patients that, along with these patients, are patients that are rising risk and high risk. They need to be managed in a population basis, and that takes coordination of care. That means they need to not be isolated. So we know that roughly equates to 25% of the people that we take care of in terms of raw population, but by volume. But it equates to about 80% of our work in primary care by time. So what do patients want from their health care? I think in general these things are true. They want to fear less about the future related to their health. They want to be more empowered to do what they want to do with their lives. They don't want to be uncomfortable. They want to be in pain. They want to feel more empowered to control their destiny and their future. They want to be understood by us and by their families and friends, and their coworkers. And they want to be listened to by us and their family, friends, and coworkers. They want a trusting relationship with us. Patients with complex conditions like chronic pain and opioid addiction don't want to feel like they're a burden, and many times they think they are. And I would submit that most patients right now with the conditions of opioid addiction or abuse and or chronic pain don't necessarily feel like they have all those things from healthcare. What do we want as providers of healthcare? I think we want the intrinsic reward that we get when we take care of people and it works out. We want to see people's health improve. We want a trusting relationship with our patients to see them feel better. We want to be recognized and respected for our contributions. We want to use all of our skills and knowledge to the best of our abilities. We want help from the others around us so that we can do that, so that we can kind of practice at the top of our training. We want some work-life balance. What do we not want? We really don't like to see the same patients over and over and over again with really no change. That things just aren't improving, that treadmill of, I see your back, and you're no different. That we don't like to hurt people. We don't like to do things that don't require our skills and expertise of those things that we train for. We hate the administrative overhead of those things that we're increasingly required to do, the endless list of regulatory burden that seems to be ever mounting in our minds. Patients with opioid abuse problems or chronic pain, they terrify us many times. They make us feel vulnerable and out of control, helpless, like I may not be able to help this person. We think we can do better by clinically integrating a team to do this, to allow more control and do a better job together. We think this looks a lot like the patient-centered medical home model. This is kind of the traditional version with the patient at the center, and all of us, along with our colleagues in care, kind of mounted around the patient in this kind of loving circle. We've kind of redefined this a bit. And we would say it looks a little bit more like this to us. That the patient is still at the center, but there's more of this directed guidance of care, and that rippling out from that center spoke, or that center hub of the patient, are these rings of care that there's guidance for direction to. Because what we found with the prior model is that sometimes too much choice leads to kind of this aimlessness or feeling of, I'm not sure what to do. So in the second model, the difference is the patient's still in the position of being the ultimate decider of their care. The chosen PCP team takes on the role of primary facilitator of those decisions. And that facilitator model is a little bit daunting for some of us. We have to decide that it's okay for us not to be the end game all the time, to be that facilitator and let the patient ultimately choose. But we also have to have the capacity to make those facilitate those decisions. And it's that capacity that we found was the primary barrier, both emotional and time capacity to do that, to help work with that team. So just assembling a team wasn't good enough. You had to have the capacity to do that, the skills, time, and emotional ability to do that. So a lot of this pilot or experiment, as Gary talked about for us, was really building this capacity to let doctors be doctors in order to facilitate good care. So first we decided who needs to be on this team of primary care, and then who needs to be available to the team. In the team, we decided we needed pharmacy support, we needed behavioral health integrated into the team, and then we needed RN case management or RN navigators integrated into the team. So those have been embedded into our primary care teams, the majority of them at this point. Available to the team, we needed chemical dependency counselors, social work, and a variety of other community resources. We take care of an area of about 12,000 square miles from the Canadian border through Moses Lake and Royal City, and each one of those communities has a different menu of community resources. So it's really important that we know what those look like, and we're pretty involved in putting together, through the accountable communities of health, what that looks like to each clinical team and their department. But the base team that's available within primary care consists of pharmacy support, integrated behavioral health, and RN case manager or navigator. Standard work is critical. Making sure that the practice team really understands the workflow and each individual's role in that workflow, that there are clear expectations for them in every piece of the work, that they have the skills to complete that work and the time to do it. I'll go into that a little bit more. And that we have supporting metrics for each piece of the work that we can ensure quality along the way. Pharmacy support was by far the easiest thing to roll out. For one thing, the doctors loved it. So basically, these are PharmDs and pharmacy techs that do the prescription refills, the non-scheduled prescription refills for the primary care teams. This is done both on-site in some teams and remotely for the smaller teams by a centralized group of pharmacists that do this virtually. This coordinates pharmaceutical refill and has reduced our pharmacy refill error by 18% throughout the system. And that's a fairly large system, well over 110 primary care doctors, and more than that in terms of advanced practice clinicians. So many thousands of prescriptions per year being done in this fashion. Marked decrease in dangerous med combinations, where they catch the prescription of opioid and benzo together, make a friendly reminder back to us and help us get a schedule to get them off of that. A tremendous increase in physician and APC satisfaction, and a marked reduction in phone calls regarding pharmacy refills back to the clinical team, so increasing time capacity for that team to focus on face-to-face medical work that can be done for the patient. Integrated behavioral health is simply not embedding a behavioral specialist inside the primary care team. This is literally putting a behavioral specialist inside the team that has open capacity on their schedule to see patients same day. So on my clinical day, I still see patients. I have a PhD psychologist who sees patients with me much of the time. So most of my patients have either chemical dependency or chronic pain. At this point, that's just what I've chosen to do on my Friday. Don't ask me why. But that's what I've decided is a good role for me. So Dr. Grass will see most of my patients either before I see them or after I see them in combination. And it's been a tremendous benefit. It takes a bit of time to learn how we work together, kind of the pitch and catch of the clinical rhythm of this model, but it's been very, very helpful. So in some cases, we basically put standard work in place to where some patients always will see the behavioralist at the time of visit. New chronic pain or new patients with opioid dependency always see a behavioralist at the time of the primary care visit, and may continue to see that behavioralist in conjunction with their primary care team. Or patients that have difficulty being adherent to the treatment plan or are stalled in their progress, whether with regard to progress in chronic pain management or their progress with regard to treatment for their opioid dependency. They'll be asked to see the behavioralist at the same time. Again, this requires a fair amount of coordination and learning how to work together, and we're still working on this. Our in-case management phase 1 was to create a centralized team, and we really stole shamelessly from the Mass General model through the Harvard system. This is how they set theirs up. We created a centralized case manager model. At first, we grew from 4 ambulatory case managers to 30. And since that time, we've then redistributed most of those ambulatory centralized case managers back out into primary care departments where they're embedded. Because then they have their own panel, they know those teams, and they can see patients face-to-face more readily. In this model, the results have been much better. They tend to learn the patients, they can be more involved, and their role really primarily isn't just chronic pain or patients with opioid issues. It's all high-risk or rising-risk patients independent of their disease state. They focus on that high-risk and rising-risk patient population, so that 25% or so that they're assigned to take care of. The support staff piece was really, I think, the piece that gave us the most yardage in this game. We built standard work through lean management processes of Kaizen, in other words, having local teams create clear expectations and standard work for each of the discrete work types within primary care, whether that's check-in, rooming the patient, the visit itself, or the discharge or depart process. Within each of those discrete elements of care, standard work was agreed upon. And standard work is, what's the best way to do this right now? You're never done. So the teams understand that there's always a responsibility for the teams to continue to try to improve on that standard and then spread that through the organization. So these are some examples of what happens at those stages. And in chronic pain, a lot of this is making sure we have the appropriate information or data sets for each patient, whether that's our pre-screening CAGE or DIAR scores, depression screening, pain surveys, etc. That happens before each visit. Sometimes these occur well before the visit. We are able to do that electronically now with patients on MyChart. In the rooming function, medication reconciliation, depression screening, which is a PHQ-2 with a reflex Q9 and a reflex suicide screen, is done by patient-reported outcome but facilitated by the rooming staff. So all of this data is gathered before the physician or the provider enters the room. And at the depart process, we've trained our depart staff to make sure that we're using appropriate teach-back technique to ensure greater patient adherence to the plan. So we give them time to teach back to us that they understand or collaborate with the plan that we've agreed upon together. We found that if we do that with a third party, essentially that depart person, we find, at least in our measurements, greater adherence or agreement with the patient to the plan. Each step, these are valuable steps, they take time, so to facilitate that, we created a new scheduling type, which basically there's 2 schedules to every day in primary care. One is the patient schedule, which includes detailed time for each staff member to do their work. The other schedule is the doctor's schedule. So essentially, we know that every patient takes roughly 40 to 60 minutes to get through our clinic. They always have. We just weren't measuring it or counting for it. So now all of that scheduled time is accounted for and now can be managed appropriately. And if we do improvements or efficiency improvements to create efficiencies, we can improve on that. But one thing to remember, this was a Fred Lee thing. It's always important to be efficient with things, processes, data, things. You should never be efficient with people. With people, we should be effective. Make the best use of the time we have. So we always found it disrespectful that we didn't schedule our staff time to do the work that they needed to do and then create clear expectations and give them the skills to do it. This has worked out extremely well for us. The results so far is that the physicians are consistently done with their day on time and have completed their documentation on the same volume of patients that they were in the past, but they're done on time. They're not hanging around at the end of the day trying to get their documentation done. The patient visits are much more completely prepped. So they have adequate data. The physician isn't digging through the computer or through the chart trying to get data. They need to do the work, or they're doing the work without the data, which is even more dangerous. Patients report a much higher level of engagement with their physician because their physician is face-to-face. They're en face with their doctor the majority of the time, not with their doctor buried in their computer. The staff are much, much happier. Our staff expectations and engagement scores have gone up dramatically since then because they feel like we've given them clearer expectation and much clearer training to do the job we've given them to do. The fact that we've respected them enough to actually give them the time to do it feels pretty good. So that's been a win. Fewer phone calls to departments because as we do an appropriate discharge process with TeachBack, patients don't have those hanging questions that by the time they get home, they call you back in the afternoon because they really didn't understand. So we think it's just better medicine. With regard to chronic pain patients, at this point, I think it's also led to the fact that now we can engage all providers in taking on new chronic pain patients. All new patients in chronic pain are done in rotation through the organization. There's a strong push to have all primary care docs take on standard work with regard to chronic pain and opioid management, expert protocols, as well as being trained up with buprenorphine training. We just did another round of training last Friday. That'll get us up to about 30 total docs that will be certified by the end of this month. So that's nearly 30%, which is a big improvement from where I was, frankly, even 4 months ago. Our targeted MED has dropped from 120 to 90 institutionally, so that's our institutional target. To completely avoid the concomitant use of benzodiazepine and opioid and any other comorbid medications with opioids, and limit acute narcotic prescriptions to no more than 7 days throughout the institution, including specialty care in the emergency room. Really use that first prescription refill request for acute medication as a red flag to look for what else is going on. A, do they have a complication from surgery or acute management, i.e. are they infected, or is there something else going on that I need to get help with? And this is working out. So oftentimes we'll get a call in primary care for a patient who's requesting a refill on their acute med prescription from orthopedic surgery, and they'll say, hey, can you talk to this patient because they're requesting refills and I'm not sure what's going on. They're not infected, so can you take a look? Unintended consequences is that this is more accountability to leadership. It may take more staffing to do this. There are going to be manpower, training, and technology requirements that we have to be accountable to deliver on. The next steps are to spread this throughout our system to make this, because it does appear to be more reliable, higher quality care. So ethically, this is a model that needs to be spread equitably throughout our system, and I'm pleased to say we're nearly there at this point. Evaluate the cost-benefit relationship honestly. We frankly leverage our rural health payment base in order to do this. We get paid an encounter rate for Medicare, Medicaid, and we're about 72% government pay. So this works for us. And we're doing a current EPIC report to report back to each clinician in primary care all their patients that have an MED that is greater than 90 for their chronic patients. And that's where we're at. I think I made it. It's as fast as I can talk.